Not yet working. Well, thank you very much, Sean, and the organizers of this meeting to give me the chance to present our ideas on this procedure. And I knew from the time we worked together that Sean is a very good surgeon. And I learned today that he's not only a good physician, but also a very good organizer and a very good businessman. So, chapeau. The prof procedure or pulmonary autograft is a complex procedure taking out the pulmonary valve and by this replacing the aortic valve with the pulmonary valve and then later on replacing the pulmonary valve. The reasoning for this is that the current valve prostheses are not perfect. This is a typical picture from a Rio Parade mechanical aortic valve, and this thrombotic rim is kind of a routine observation. They always have some thrombus at the interposition of artificial tissue and the normal tissue. And the survival rate is, this was an old Vienna picture of our valve cohort patients group, that they never achieve a normal long-term survival. And this is given by this paper. They compared the normal life expectancy of a 45-year-old person is around 30 to 35 more years. Once you have a valve implanted, this decreases to 20 years, 15 years. This kind of levels out. So the older you get, the less difference in life expectancy you have with an implanted valve prosthesis. But for the younger people, this is certainly a problem. And this was also compared from the Vienna group. They looked up the series of autografts and propensity matched this group with mechanical valve, with patients having undergone an aortic valve replacement with a mechanical valve. And you see very obviously that the life expectancy of the autograft population was close to the normal population, Austrian matched population, which is the green line. And once you have implanted a mechanical valve, you have a decrease in life expectancy. So this kind of corroborates the previous findings. Now we started out and we were trained by Egbert Boss from Rotterdam in the RAS procedure in the early 90s. And so this was the presentation of the first 35 cases. He trained us in doing RAS procedure like this, cutting the aorta and sewing in the tubular pulmonary valve. And we pretty early observed that this dilates. So we put in the autograft inside the annulus and reinforced it. So this is a normal angio of an autograft. This is of a switch operation. So it's a different surgery, but what happens is that the pulmonary root does not sustain the aortic pressure long term. And this is from the German-Dutch ROS registry. If you kind of reinforce the aortic root, you have only a slight increase in diameter. If you don't do it, you have a significant increase. The reasoning not to reinforcing it with the dacron was this type of studies. Once you put in a rigid segment in the aorta, you increase the pressure load downstream and upstream. So the chance of developing aneurysms or deteriorating the ventricular function is given. So this was the reason not to support it completely, but what we did, we wrapped the aortic wall and wrapped it with a resorbable mesh with Vicryl mesh. So now to get an idea on the results of the autograft procedures, I sent our middle daughter to find out the results of the Vienna group. So that was the first 100 patients with a mean follow-up of 13 years. And on the autograft, we had 4 reoperations in more than 1,100 patient years. So it's a very low rate. And there were 2 technical problems and later on 2 dilatations. On the right side, it was a little bit more. We had observed 2 cases of endocarditis in drug addicts and 5 structural valve defects. So only 5 reoperations, but 7 reinterventions. 2 patients received transcutaneous valve. Now, this was the slide that led us on a wrong track. This was a very large series congenital surgery from the Mayo Clinic, and they showed that on the right side the bioprosthetic valves had a better long-term durability than the homografts. The overall homograft performance was not bad, and the second was the Stuttgart group. They compared homografts versus bioprosthetic valves with reasonable results. So we went on using bioprosthetic valves on the right side. This was a serious mistake. We observed strictures, and this is seen here. It's a scar stricture of the right outflow tract. We solved this in the similar way Hans Sievers did it for the pulmonary homografts. They also tend to have small slight strictures, but this pushed the problem downstream. So then we didn't see the proximal stenosis, but we saw the distal stenosis. So these are the results compared homografts versus bioprosthetic valves, and it's very obvious that this was a bad option. Now, generally the reoperations on the left side. This is a very peculiar patient. We had to reoperate. We had to replace 3 valves. After Ross procedure, he underwent liver transplantation. He was on immunosuppression and on vitamin D drug. So he calcified all his heart skeleton. That's the autograft, that's the mitral valve, that's the the homograft. So we had to replace all this. This is peculiar. But what more often is, well, step back. If we implant an autograft into an aortic root, we have to adapt the 2 sizes. This we learned very early in the series, so we kind of strictured the annulus and fitted it to the size of the autograft. And the second thing we had to do, as quite a number of our patients had a bicuspid aortic root, and in the bicuspid aortic root, the non-coronary sinus is more deep in the left ventricular outflow tract than the others are, so we positioned the autograft in order not to distort it slightly supraannular. This was not that good an idea, as we observed pseudoaneurysms. This is the reoperations we had to do. There were 4 cases of endocarditis, 6 cases of the pseudoaneurysms, unless we solved this problem. We had very few cases of structural problems, and later on we saw the aortic dilatation. So these are the areas where we can improve the procedure. We did not observe a difference in aortic dilatation between bicuspid root or tricuspid root, whether we did anything on the dilated ascending aorta or not, so there was no difference in this respect. When we looked up our results, and this goes back to prevention of dilatation of the aortic root, when we looked up our results for the David procedure, so once you pull in the aortic valve into a prosthesis to cure a dilated root, we observed in this group a normal survival, and we had a very low rate of reoperations or moderate results, which is an AI grade 2. So this is for 10 years with more than 80%, I think, very reasonable results. So then we thought of, why don't we reinforce the autograft primarily with Dacron? There were several techniques described. I show you the technique we finally stepped on. We put 2 sutures below the annulus, put in the autograft, and secondarily wrap the new aortic root and the old annulus with a Dacron prosthesis, cut out generous holes for the reimplantation of the coronaries, and do a normal anastomosis, so not to distort the sinotubular junction, and kind of slip the Dacron prosthesis over the new root. And in the case of a dilated aortic ascending aorta, you can wrap the further ascending aorta so you don't have any Dacron direct in contact to the bloodstream, which helps in addition. So then we compared our new results to the old results. The reoperation on the autograft was slightly worse with the mistakes we made with the pseudoaneurysms and these things compared Vienna to Frankfurt. For the right ventricular outflow tract, it was obvious the bioprosthetic valves in this position do not perform as well as the homografts. But still, if we go back to the complications the patient would expect, or would have to expect with a mechanical valve, we see that we had actually virtually no structure. That's about the stroke rate the normal population has, 0.6% per year. Then we had a lower rate of endocarditis. We had, of course, no bleeding because those patients didn't need anticoagulation for the valve. There was a very low rate of endocarditis, but we had a slightly higher rate of re-intervention. Now, once patients come to reoperation, usually we see a normal aortic valve. So you can repair it unless the patient, as we had observed some, had a bad ventricular function and are over 60 years old, then you better replace this valve with bioprosthesis. So how look the results overall? Stuttgart results, that's a reoperation rate or insufficiency rate over 10 years. It's around 95% event-free. The same results are achieved by the Lübeck group. And if you go back to the German-Dutch registry, you see the reoperation rate is very much depending on the sufficiency of the support of the aortic root. So this is our Frankfurt results. We had overall a rate of 18 reoperations on the autograft, but finally only 6 patients had to undergo a valve replacement. All others could be repaired. There were 9 embolic events caused by atrial fibrillation. We had 9 events of endocarditis, no case of anticoagulation-related hemorrhage, and for the atrial fibrillation, finally 13% of the patients finally needed anticoagulation. And if you go into laboratory parameters, autografts has less LDH, no hemolysis, and have less fibrinogen, which in turn can increase atherosclerotic changes. So one of the major assets of the autograft procedure is the normal long-term survival. This is again a CVAS, a Lübeck group. So this is a complete normal survival rate. This is the Frankfurt results, also a normal survival rate. This is the Vienna results. And we randomized a small group of 20 versus 20, and the survival rate of the mechanical valve patients is much inferior to the autografts. With this, I want to sum up. When respecting certain technical principles, the ROS procedure provides excellent and stable hemodynamics in the long term. Valve-related complications are reduced, actually to reoperations and reinterventions, and are mostly due to conceptual problems. Once you solve the problem of the right outflow tract, which is pretty much solvable, and the late dilatation of the aortic root, you may achieve much better results than we have achieved it up to date. Degenerations are rare. The autograft provides a durable biologic valve, and the right ventricular outflow tract replacement is a possible long-term problem, but most of this problem may be cured percutaneously in the future. The normal long-term survival, normal long-term survival appears to be the major asset of this technically demanding procedure. Thank you.